Therapeutics of the liver cirrhosis and hepatic encephalopathy. Case 1. A 20-year-old woman who is hepatitis B S antigen positive and hepatitis B E antigen negative. Her HPV DNA is 1.2 million copies per ml and approximately 250,000 international units per ml. She had mild portal inflammation, no fibrosis, serum ALT is 60, and the upper limit is 40. What is the plan of management in this patient? So age of the patient is 20 year and the hepatitis S antigen is positive and E antigen is negative. There is slight increase in the DNA copies, HBV DNA, and no fibrosis, and slight increase in ALT. So the management plan includes I would follow this patient without recommending treatment at this time because the patient is young and has only mild histologic changes on liver biopsy, and it is reasonable to observe the patient for time being. So I would repeat liver function test every 3 to 6 months, and I would start the treatment only if the ALT is persistently elevated and the hepatitis B V DNA remains high after 1 year of the observation. So now there is no need for the treatment. Case 2. A 25-year-old Asian man who is HBS antigen positive, HBE antigen positive, HBV DNA 70 million copies per ml, mild inflammation on biopsy, and serum ALT is 100. So it is, we can say, near about 2.5 times increase in the ALT, and it is also indication of the therapy, but the ages of the patient is 25 year. What is the plan of management of this patient? Given the young age of the patient, pegylated interferon should also be considered because the finite duration of the treatment, because the age of the patient is well and the liver is well compensated. Entecavir, despite its high cost, may be a better first line oral therapy. So you can use pegylated interferon because the age of the patient and the entecavir is better and the first line oral therapy for the management of HBV. Tenofovir would be a reasonable alternative in countries in which it has been approved. It is less expensive than entecavir, but the small risk of the nephrotoxicity. So it should be contraindicated in the renal failure patients. So treatment plan for the HBV is entecavir, that is nucleoside reverse transcriptase inhibitor, and the pegylated interferon you can give as per the we discussed the indications before. Case 3, a 50-year-old Asian man who is hepatitis S antigen positive, hepatitis B antigen negative, and serum ALT is 75, upper limit 40. He has moderate hepatitis with bridging fibrosis on liver biopsy. Fibrosis. And what is bridging fibrosis? Bridging fibrosis refers to the presence of fibrosis that reaches from a portal area to another portal area. And what is the management plan of this patient in response to the remarkable bridging fibrosis? Although this patient has only a mild elevated serum ALT, I would recommend treatment based upon the advanced histologic features on his liver biopsy if his serum HBV DNA is more than 2000 international units per ml or the 10,000 copies per ml. Entecavir or tenofovir is preferred for the oral treatment, and pegylated interferon may be used cautiously in patients who have bridging fibrosis and no evidence of clinical or biochemical decompensation. So again, the treatment plan includes entecavir, which is nucleoside reverse transcriptase inhibitor, and tenofovir, which is nucleotide reverse transcriptase inhibitor. And as the patient has bridging fibrosis, you have to take care of the precautions while prescribing interferons. Case 4, a 75-year-old woman who is hepatitis B S antigen positive, hepatitis B E antigen positive, serum ALT 50 international unit, upper limit is 40, HBV DNA 8000 copies per ml. She has ascites and known esophageal varices. She is not considered to be candidate for liver transplantation. Yes. Now the age of patient is 75 years, and the remark is ascites and esophageal varices. So it is also the case of the hepatic encephalopathy. Page, these patients due to age of 75, treatment with interferon is not an option for this patient because she has decompensated cirrhosis, ascites. Therefore, entecavir or tenofovir is preferred. Entecavir may be a better choice because the patient with decompensated cirrhosis are at high risk of renal failure and the age of the patient is 75. High risk of the renal failure is also due to tenofovir. So best is entecavir. Case 5. A 40-year-old man with pre-treatment ALT 129 unit international unit per liter, moderate inflammation on the liver biopsy. He remains HBe antigen positive, but HBV DNA is undetectable by PCR polymerase chain reaction after 1 year of therapy with lamivudine. Patient age is 40 year. What is the remarks? Remark is ALT 129 and the he was on the therapy near about 1 year with the lamivudine. Lamivudine is antiviral drug, belongs to category of nucleoside reverse transcriptase inhibitor, and his HBV DNA is undetectable by PCR. Lamivudine may develop resistance, so we can change to the entecavir, and we have to check again the HBV DNA. Patient who have been on lamivudine and have undetectable serum HBV DNA for many years can continue on lamivudine, especially if virus was suppressed to undetectable level within 6 to 12 months of initiation of treatment. So what is the suggestion? Patient who are on lamivudine therapy and undetectable serum HBV DNA can continue on the lamivudine. If the virus is suppressed and undetectable within 6 to 12 months of the initiation of the therapy, and the same happens for this patient. Patients who have only on lamivudine therapy for 1 to 2 years should be switched to other drug that have lower risk of resistance, including entecavir, may be used in patients who had been exposed to lamivudine for a short time and in whom the serum HBV DNA is undetectable. So the best way, the patient can continue on the lamivudine, or because the lamivudine having the higher chances of the resistance, so switch to the entecavir is also the good option. Second option, obviously, from the nucleotide reverse transcriptase inhibitor category, tenofovir would be a better options for the patients who have been on lamivudine for more than 1 to 2 years, but taking the consideration of kidney functions. Case 6. A 68-year-old man, the age is 68, who is hospitalized with low grade fever, abdominal pain, anorexia, and jaundice. Serological evaluations reveals he is HBs antigen positive, IgM anti-HBC positive, with serum HBV DNA level of 1.5 million copies per ml. Serum ALT is 2000 units per liter. Total bilirubin is 8 milligram per dl, and INR international normalized ratio is 1.5. Other causes of liver disease are excluded. The patient is not known to be carrier for HBV. However, he is bisexual and thus has potential risk factor for HBV infection. His aminotransferases INR and total bilirubin rise slightly during the first 2 days of the hospitalization while awaiting the result of above serology. What is the plan management of this patient? What is the remark? The age is 68-year-old, fever, jaundice, IgM anti-HBC positive, HBsAg positive, and the DNA HBV DNA copies are 1.5 millions per ml. It would appear that this patient has acute hepatitis B viral infection. Although reactivation of the chronic HBV infection is also possible, the patient's advanced age is a risk factor for morbidity and possible mortality from acute infections. So, in patients suspected to have severe acute hepatitis, telbuudine, lamivudine, adofovir, tenofovir, or entecavir would all be acceptable option given as monotherapy. Single drug, choose any one drug, use the single drug. Monotherapy, as the duration of treatment should be short. Treatment can be stopped after confirmation. Two consecutive tests 4 weeks apart, 1 month apart, that the patient has cleared antigen of HBS. Case 7. PK is a 19-year-old medical student who is enrolled in medical college this year. He has no history of hepatitis and has not been immunized for hepatitis. The question is, should PK receive hepatitis B vaccine? What you will do for him if you decided to go give the vaccine? What is the dose? What adverse effects are likely to occur in PK from vaccinations? And PK didn't complete all hepatitis vaccination regimen. What do you recommend? So this case is uh, belongs to the vaccination protocol. Now, for answer of the 1, 2, 3 and all these things, should PK receive hepatitis B vaccine? So what is the indication for the hepatitis B vaccine? And in the case, it is mentioned that he has not been immunized for hepatitis before. So what is the indication to get the vaccine of hepatitis B? Check for the hepatitis S antigen. If the hepatitis B S antigens positive, you need treatment, not the vaccine. And please note that the vaccine give prevention. Vaccine will not treat the infection. So if the patient has HBs antigen positive, treat, not vaccine. If these antigens are negative, check for the HBs antibodies. If antibody negative, then you can give hepatitis B vaccine. If hepatitis B S antigens and antibodies are negative, you can give hepatitis B vaccine. And if third condition, if hepatitis or we can say HBs antigen is negative and antibody positive, so it may be due to natural immunity from mother to the baby. Now, what is the dose and what is the duration of action? Hepatitis B vaccine should be given 1 ml. We discussed in the before the start of session. Same uh, intramuscular in the deltoid muscles. Three doses at 0, 1, and 6 months. And the last one, the 6 month dose, is considered as booster dose to help the people, to healthy people. So one dose is 1 ml equivalent to 20 microgram, give immunity for 5 to 7 years, or 10 at most need booster dose every 7 to 10 year. Here here there is a spelling mistake. They written poster, poster. It is not poster, huh? It is booster, boster. So please take a note. Neonates need three doses at 0, 1, 6 month, or at 2, 4, 6 months, and the dose should be zero point 0.5 ml as we discussed in the lecture. If the patient age is from neonates to less than 19 years, the dose should be half, zero point 0.5 ml. And also for the immune suppressed patient which is having the HIV, dialysis, need four doses at 0, 1, 2, and 6 month, or 0, 1, 2, or 12 month, and then the booster dose annually for life. What are the adverse effects likely to occur in the PK from the vaccination? As we discussed in the start of lecture, pain, fever, local hypersensitivity, flu-like symptoms, rarely seizures, and the seizures may be due to wrong injection into the vein instead of into the vein or artery. PK did not complete all hepatitis vaccination. What do you recommend? If the second dose is delayed more than 2 months, because the second dose schedule is at after 1 month, second dose schedule is after 1 month, and if the second dose is delayed more than 2 months, start the course again. And if the second dose is not delayed by more than 2 months, give it when remember. And if the third dose is delayed by 12 months, and what is the schedule of the third dose? 6 months. And if it is delayed by 12 months, start the course again. And if it is less than 12 months, take it when remember. Yes. This question is also very important for your MEQ point of view. What is the dosing if the patients forget to take the second or third dose? So for the second dose, the deadline is within 2 months, and for the third dose, the deadline is within 12 months. Case 8. JH is a 25-year-old medical intern came after accidentally sticking himself with contaminated needle while withdrawing blood from HBS antigen positive patient, and JH was not vaccinated. Yes, 25-year-old, he is not vaccinated and stuck with the contaminated needle from the blood of HBS antigen positive. The risk to have hepatitis is 1 to 3%. Give him at the same time 3 to 5 ml immunoglobulin antibody IgM within 24 hour plus hepatitis B vaccine at 0.16 month. It will provide 95% protection, and give each injection in separate arms. If inborn to mother has hepatitis B, give him besides the vaccine at 0.16 month, and the dose is half of the dose, zero point 0.5 ml of hepatitis B IgM antibody at the same time within the 12 hour of delivery. So this is an additional point for the inborn. If the mother has HBV positive, so for the inborn baby we have to protect from the HBV, so we have to give vaccine at the same time and within the within the 12 hour of the delivery. And there is also addition, in case of the rape, give passive immunization to lady within 2 weeks, chances to prevent the chances of the HBV infection. There is a note: anti-HBS antigen and anti-HBAE. It means if present means the immunized patient. That means antigen and antibodies present. There is anti-HBS AG and anti-HBAE. This indicates the person is immunized. Case 9. We have 10 cases. Yes, 11. 3 cases. We will see the 3 cases, and so 3 cases only. Case 9. TM is a 55 years old female known chronic hepatitis B patient presented to hepatology clinic complaining of fatigue, abdominal pain, and darkening of the urine for last month. What drug therapy should TM receive for her chronic hepatitis B infection? The age of the patient is 55, women, and the chronic HBV. What adverse effect do you expect in TM during the therapy? and what are the baseline parameters that should be done before and during the therapy. As a chronic infection, interferon alpha 2A should be given in the concentration of 180 microgram per week for 48 weeks. And we have the antiviral drugs including entecavir, adifovir or lamivudine. So these are the drugs for the chronic hepatitis B viral infection, and we discussed before. What are the baseline parameters that should be done before and during the therapy? So before the therapy, you have to check LFTs, ALT, bilirubin, prothrombin time, serum creatinine, electrolytes, complete blood count, platelets, hemoglobin, and the most important is pregnancy. Also test T4, chest X-ray, blood sugar, and HB viral load and viral replication, and start the therapy. And after therapy, again check what is the benefits from the drug. So these all lab test indicates the benefits from the therapeutic drug regimen which was prescribed before. That's why baseline means before the start of therapy, and after the therapy you have to again check to compare with what are the benefits of the regimen. What adverse effect do you expect in therapy? So this question is adverse effect. You can, yes, as I told you. What are the interferon adverse effects? Psychosis, flu-like symptoms, hypersensitivity, fever, fatigue, nausea, renal failure, vomiting, myalgia, hyperglycemia, hyperthyroidism, bone marrow suppression, hepatitis, and lactic acidosis. Case 10. SN is a 42-year-old man with acute hepatitis C, and for the acute, we need only interferon. Do you recommend therapy to prevent chronic HCV? Yes, we need the therapy. And the therapy includes pegylated interferon alpha 2A alone, 180 microgram per week for the 3 to 6 month. It is more potent and can be used in lesser doses with less adverse drug reactions than ordinary interferon. So pegylated interferon alpha 2A in the dose of 180 microgram per week for 3 to 6 months is only therapy for the acute hepatitis C infections. SN didn't receive therapy during acute illness. He presented with the chronic hepatitis C. What treatment would you recommend? Now, the treatment for the chronic C virus according to the genotype, as we discussed before. Pegylated interferon alpha 2A drug of choice mainly for HCV infection. So, suppose there is a question in your MCQ, which of the following is a drug of choice for the treatment of the acute hepatitis C viral infection? Pegylated interferon alpha 2A in the dose of 180 microgram per week plus ribavirin, which is nucleoside reverse transcriptase inhibitor, drug of choice for the treatment of hepatitis C viral infection in the dose of 800 to 1200 milligram per day in divided doses, and duration of therapy is 48 weeks. And if the patient is from the Europe, North America, Saudi, Egypt, and Africa, please remember These patients are considered genotype 1 and need 48 weeks treatments. And if the patients from the China or Asia need 24 weeks of treatment. And if you don't know the patient from which genotype, give maximum 48 week. Case 11, we have less than a minute. Meeting will be disconnected, so you can please join again. Case 11, WH is a 35-year-old man who developed nausea.